Hello everybody, welcome to this video on Psammoma bodies. So just briefly, Psammoma bodies are concentrically laminated calcified spherules, which you can see here. They kind of have this glassy appearance. And they are seen in papillary thyroid cancer, serous ovarian carcinoma, meningioma, mesotheliomas, and prolactinomas, amongst some other disease processes. So we'll start off by discussing papillary thyroid cancer. So papillary thyroid cancer is known to have nuclear grooves and inclusions. These inclusions are actually nuclear pseudo-inclusions. They're invaginations of the cytoplasm and appear as nuclear membrane-bound vacuoles, but you'll notice that the color should be the same as the cytoplasm because it is in fact material from the cytoplasm. And then you also see something called orphic anni-eyes, which is another way of saying optically clear nuclei. The most common mutations are going to be BRAF and RAT/PTC. These patients have a good prognosis. And then in terms of IHC, it's going to be positive for HBME1, CK19, and negative for CD56. And normal thyroid is positive for CD56. And usually you have to have papilla or invasion for diagnosis. Next we have meningiomas. So when we think about meningioma, it's important to remember that there's nuclear clearing or pseudo-inclusions. There can be cellular whorls. They have indistinct cytoplasmic boundaries. If it's multifocal, then you want to think of NF2, which is a mutation on chromosome 22q12. There are many different types, including fibrous, transitional, microcystic, vascular, and submomitous. Next, we have mesothelioma. So the most common type is diffuse pleural mesothelioma, which can be separated into epithelioid, sarcomatoid, or biphasic/mixed. Epithelioid is the most classic and common presentation. Classic formation of this is going to have tubulopapillary formations, abundant acidophilic cytoplasm. And there are other variants as well, including deciduoid, papillary with rhabdoid features, lymphohistiocytoid, and desmoplastic. So with IHC, it's going to be positive for calretinin, positive for WT1, positive for CK56 and D240. It's going to be negative for the following markers, which are positive in adenocarcinoma, so MOC31, BREP4, CEA, CD15, MUC4, BG8, and Claudin-4. And lastly, I just want to talk about serous ovarian carcinoma briefly. There are different ovarian subtypes in general: serous, endometrioid, clear cell, mucinous, seromucinous, or Brenner. And these are all subdivided into benign, borderline, and malignant. So low-grade serous and high-grade serous are actually different disease processes. They were once thought to be continuous on a spectrum, but now they're starting to understand that they're actually two different disease processes. So on the spectrum of benign, borderline, and malignant, we start off with benign serous cystadenoma. You'll usually see cilia for this, and then we move on to serous borderline, which has an absence of stromal invasion. And next we have low-grade serous carcinoma, which has KRAS and BRAF mutations. Usually there's not going to be as much cilia present. These patients will have a normal P53 pattern, lower mitotic rate than high grade, positive CK7, positive CK8, 18, 19 EMA, B72.3 and Vimentin, and negative CK20. And then it's going to have high grade is going to be positive for WT1, P16, and there's going to be a P53 mutation type present. So that's all I have for Psammoma bodies and some diseases that are associated with them. I hope this video was helpful for you. Feel free to like, comment, and subscribe, and I will see you in the next video. Thank you. Bye.